Good morning, ladies and gentlemen, dear Mr. Chairman. First of all, I would like to thank Professor Aziz Alif for his kind invitation to Baku. And I'm very grateful being here and for the help you gave me within the last 3 years. Now, I would like to have a talk about the treatment concepts in head and neck cancer. So, what type of cancer do we treat? We treat squamous cell cancer. You know, 95% of all head and neck cancer are squamous cell cancer. Only 5% have different histology. What's about the location? We treat cancer of the oral cavity, pharyngeal cancer, and pharyngeal cancer can be divided in nasopharynx, oropharynx, and hypopharynx, and last but not least, laryngeal cancer. As you know, nasopharyngeal cancer is a disease which is endemic in the south of China. In the Western world, nasopharyngeal cancer is rare. So I want to spare it. You know, the radiochemotherapy, according to Sharaf, is treatment number 1 for nasopharyngeal cancer. So I want to spend some minutes to the other locations. What options do we have for treatment? Surgery, you all know that. Radiotherapy, chemo, and immunotherapy. You know, there's only one compound which you can use for immunotherapy in head and neck cancer. This is, unfortunately, this is not by Roche, but this is Erbitux. It's cetuximab. Now, whenever necessary, you should combine one of those treatments. Combine radiotherapy after surgery or combine radiotherapy with chemotherapy or immunotherapy. And you should have a look to the guidelines because it's outlined very well which type of treatment you should use for the different cancer. So I like this picture very much. It shows you a dinner, 4 people eating, drinking, discussing. And what you have to know that we, if you treat head and neck cancer, we interfere with very important functions. That means voice, and voice means communication. You speak, you communicate. That means nutrition, drinking, eating. And not only chemotherapy interferes, you all know that surgery as well interferes with quality of life and function in terms of swallowing, speaking. Now, the definite treatment for a certain patient depends more or less on location of the primary. I think you know that. TNM stage, ECOG. The biological age of the patient, what means biological age? We all know patients who are, let me say, 58 years, but they look like 82 because most of our patients drink alcohol and they smoke. So the biological age for the decision of treatment is very important. And the last is the availability of the patient. That sounds funny, but what means availability? We all would be happy if we live in Houston, just on the other side of the road of the MD Anderson. Then we can go there, we have our treatment, we go back home. That's quite nice. But we treat patients who live in the countryside, 203 kilometers from our hospitals. And if you have a laryngeal cancer, vocal cord cancer, maybe you can do partial laryngectomy You save the larynx. But then you have to do logopedic therapy after surgery. You have to do rehabilitation after surgery for a long time. But if the patient goes back home, you can't do that. And he will aspirate and he will die on pneumonia and not on his laryngeal cancer. So think about that. Now, when do we recommend surgery or surgery followed by radiotherapy or radiochemo, or perhaps concomitant radiochemotherapy or radioimmunotherapy? Now, the most important thing is, what you have to ask yourself is, what is the oncological safety? In terms, you have to do the oncological safe treatment. The first goal in our treatment is oncological safety, and the second goal is function. If it is possible, try to preserve function. Now, we continue with the different localization of the primary. Let's start with the oral cavity. In the oral cavity, the disease-free survival and overall survival is better with primary surgery and radio or radiochemotherapy in the post-operative setting. If you have a cancer of the oral cavity, the problem in primary radiochemotherapy is a recurrence rate up to 46%. In smaller tumors, that means T1 and T2 tumors, it's not a problem to do a local resection of the tumor, and you will not need tissue transfer. This shows you cancer of the lateral side of the right tongue. You can do surgery even if you have a safe margin from 1.5 centimeters. You do a hemoglossectomy. The patient will be fine after surgery, and you add a radiotherapy. But in this case, this was a patient with a recurrent tumor of the floor of the mouth with an infiltration of the mandible. So what we did is we used a plate. This plate was preformed, and you can use the plate very easily during the operation, during surgery, and you can remove the bone as well. So in oral cavity cancer, the recommendation is for small tumors, do surgery if possible. And only for very advanced tumors where you cannot do any surgery, you should use radiochemo. So let's switch to oropharyngeal cancer. It's interesting that in early stages, T1 and T2, radiotherapy or radiochemotherapy shows exactly the same results as surgery. We as surgeons believe that the small tonsillar cancer, T1, it's easy to do surgery. It's like tonsillectomy. So we believe that we are better off with surgery, but that's not true. In small tumors, radiotherapy shows more or less the same data. In the advanced stages of oropharyngeal cancer, the surgery may cause severe functional problems for the patients. So in those cases, you should think about primary radiochemo. And there is another issue in oropharyngeal cancer. This is HPV, human papillomavirus. The HPV infections nowadays are approximately 40% of all oropharyngeal cancer are HPV positive. And as you know, the prognosis of HPV positive cancer is much better than HPV negative cancer. At the moment, nobody knows exactly what's the reason for that. But regardless if you do surgery or radiotherapy or radiochemo, the prognosis is much better. Now, for instance, this is a patient with a small T2 cancer of the retromolar triangle and the tonsil. But the problem was the tumor was attached to the mandible. It infiltrated the periosteum. So what you should do is remove the tumor with a safe margin and at the same time remove the bone, because otherwise you will get a recurrent tumor. So you can remove it, you can do reconstruction in this case with a plate, and then we use the radial forearm flap for the inner lining. And the patient is well off. He gets a radiotherapy after treatment, he can swallow, he can speak, he has good function after treatment. Now, in oropharyngeal cancer, you know, the cancer of the posterior pharyngeal wall and the base of the tongue are very good for CO2 laser therapy. It depends how familiar you are with CO2 laser surgery, but in those cases, it's one of the best options to get rid of the cancer. It is very important that you know the CT and MRI scan before you go into surgery. You need contrast media for all CT and MRI scans. It doesn't make sense to make an MRI without contrast media because you cannot outline the tumor. And as a surgeon, you would like to have knowledge about the size, the infiltration depth of the tumor. That's what you have to know. Because the most important thing in terms of survival is the R0 resection. That means resection within safe margins. And it doesn't make sense if you resect 98% of the tumor, 2% are left, send the people or the patient to the radiotherapy because you think radiotherapy will kill the 2% of the cancer cells. That's not true. You have to do an R0 resection. Now, HPV positive do better, that we know. Now, let's switch to the hypopharynx. Before you start treatment in head and neck cancer, you should do a pan-endoscopy under anesthesia. Why? Because you have to define the borders of the tumor. Look to the hypopharynx. If you look to the CT scan in hypopharyngeal cancer, you cannot discern between the larynx, the hypopharynx, the medial wall, the lateral wall of the hypopharynx. You have to get in, you have to use a microscope, then you will see if the laryngeal cartilage, if laryngeal structures are involved by the hypopharyngeal cancer. Now, the small hypopharyngeal cancer are ideal goal for CO2 laser again. The bigger one I wouldn't do with CO2 laser because it's very, very complicated and the recurrence rate is high. On the other hand, as soon as the laryngeal cartilage is involved by the tumor, you should do radical surgery in terms of laryngectomy, total laryngectomy, or total laryngopharyngectomy. That means you have to use jejunal grafting or a pectoral major flap for reconstruction of the pharynx. This is a case of a hypopharyngeal tumor. You can see on the right side the cancer mass, and it destroys parts of the cartilage of the left-sided larynx. So what's the consequence? We have to take it all, a total laryngopharyngectomy. Now, the problem is, if you have a T2 or T3 hypopharyngeal cancer, if you go in there for surgery, the patient will have aspiration after surgery. He will have problems with swallowing. And in those cases, you should think about primary radiochemotherapy because this is organ sparing and function sparing. You will help the patient because after radiochemo, he will have his side effects, long-term, short-term, long-term side effects by radiochemo, but the patient prevents his voice box. What's about radiotherapy, we will go into detail a little bit later. Now, larynx. You know, the larynx you can divide in supraglottic, glottic, and subglottic. Let's start with the supraglottic cases. The only thing you have to mention in supraglottic cancer is the metastasization rate is very, very high. So if you do surgery to supraglottic cancer, you always should add a neck dissection, regardless if you have an CN0 stage, that means no positive nodes clinically, because you never know if there is a microscopical disease within the lymph nodes. Again, the smaller one, T1 and T2 lesions, can be managed by CO2 laser surgery or open techniques. You know, the partial laryngectomies, in the supraglottic case, Gluck-Sorensen, that means horizontal partial laryngectomy. Now, glottic cancer. The T1A cancer of the vocal cord is the #1 indication for the laser. That's a little bit different in the States. You know, in Europe we have a big experience with laser surgery for laryngeal cancer. In the States they use more or less radiotherapy for those types of cancer, but we think that we have advantages with the surgery. Sorry. Perhaps we can start the video. It's quite easy to do, you know. That's a left-sided vocal cord cancer. You use the laser beam, just outline your resection border. And it's very interesting in laser surgery. I think it's the only type in surgery where we divide the tumor, we cut through the tumor because we want to see the cross-section plane of the tumor, and then we can be sure to resect the whole tumor. This procedure lasts about 20 minutes, and after 20 minutes you finish. The patient go home within 2 days, and you have to compare that to 6 weeks of radiotherapy in vocal cord cancer. So that's a difference, 3 days against 6 weeks of treatment. Now, on the other hand, T1B and T2B cancer of the vocal cords are the most underestimated laryngeal tumors. This is a patient we did laser surgery for a T1B vocal cord cancer, well, 1 year before this surgery. He got a recurrent tumor, and if you look to the specimen, we had to remove the thyroid gland as well because the tumor left the voice box. And you see on the right side vocal cord, you see the tumor, the recurrent tumor, but the tumor left the larynx. It grows to the thyroid cartilage, to the thyroid cricoid ligament. Then it breaks through the ligament and it goes to the neck. And that's a tragedy because then the T1 laryngeal cancer switches to a T4. So this should not happen. But actually, sometimes we have bad luck. Now, the subglottic cancer, you know, it has a very poor prognosis. The only thing you can do is radical surgery, laryngectomy together with neck dissection, the compartment, the anterior compartment, and the paratracheal nodes, and then send him to radiochemotherapy. Now, we're coming to the end. Just some sentences to radiotherapy. Radiotherapy can be used as definite primary treatment in the post-operative setting and combined with chemo or immunotherapy, either as an induction chemotherapy or induction therapy in the definite setting, that means concomitant radiochemotherapy, or in the post-operative situation. If you use it in the definite treatment, we use 70 to 72 grays for the primary site, and if CN0, 60 gray to the neck. If you combine it with chemotherapy, you add 3 times 100 milligrams of cisplatin. Now, In the post-operative treatment, you do surgery, and after surgery, you use 60 gray for the primary side, and 60 gray if the lymph nodes are involved, and if they are uninvolved, only 50 grays. Now, what means risk factors? If the patient has an extra capsular spread, that means the lymph node ruptures and the cancer grows into the neck, then you have to add chemotherapy, 3 cycles of 100 milligram per square cisplatin. Now, all these data you find in the NCCN guidelines. The NCCN guidelines, in my opinion, are one of the best worldwide, and you will find a solution for each single case you treat. Just go there, and the web page you need has this address. Now, at the end, the induction chemotherapy. Induction chemotherapy today means you start with 3 cycles of TPF, the taxane, platin, and 5-FU, 3 weekly. But don't forget, it's a very, very toxic therapy. When we did our trial in Austria with 50 patients, we lost 2 patients due to chemotherapy, and that's quite a high amount. So if you collaborate with a medical oncologist, please use this collaboration. Don't do it by yourself. And the thing is, if the induction chemotherapy won't help the patient, so you find the tumor progression or no shrinkage of a tumor, you should stop the induction chemotherapy after the 2nd cycle and then continue with surgery. Only if you have a partial response or, let me say, near complete response, then you can continue with the 3rd cycle, switch to radiochemo, that means radiotherapy together with cisplatin. Now, this is only an example how we do it in our hospital. We have schematics for the different radiochemotherapies, so everybody knows, the doctors know, the nurses know how to do the different schemata. Now, what's the take-home message? In early stages, you can do surgery with a very good success rate. But if you compromise function, that means bigger T2, T3, smaller T4 cancer, then you should try to do radiochemotherapy because you will help the patient in terms of function, in terms of organ-sparing treatment. And all tumors which show bony or cartilage involvement should be operated, should be resected by surgery, because radiochemotherapy won't help patients who show an involvement of mandibular or the cartilage of the thyroid or cricoid. So, thank you very much for your attention. I hope I could tell you something about the concept we use. I think it's an international concept. Thank you very much.